Fiction, our show every week where we bring you the truth about fertility, try and dispel all the myths and help improve your cycle and your fertility chances. I am Dr. Rahi Victory. I am a reproductive endocrinology and infertility specialist. And off to the side where you cannot see him is my trusty sidekick, Tariq Ibrahim from Ibrahim Strategies Group. And he is running the show for us. So welcome to the show tonight. Make sure if you are watching that you hit that like button. We are very open to your comments and subscribe. So on YouTube, you can subscribe to our YouTube channel, which consistently grows all the time. On Instagram, follow us. On Facebook, you can join on as well, and on Twitter. So make sure you hit those buttons and let us know what you think of the show. And we are always looking to improve. So I hope everyone's had a good week. All things in the world of COVID seem to be actually finally beginning to settle down a little bit. So that's a very positive trend and a positive sign. So hopefully your family is all well and you guys have had a nice Thanksgiving if you're Canadian. Excuse me. And if you're American or from elsewhere, you're looking forward hopefully to your Thanksgiving, which is coming up soon. We just had our Thanksgiving, and I need to give a huge shout out to my mom, who came and stayed with me and my nephew for the last 2.5 weeks while my wife was away. Without my mom, my nephew and I would have starved to death. So it was very good of you for coming to rescue us, Mom. So I love you, Mom. You're amazing. And thank you for being the best mother anyone could ever ask for. So the topic at hand is about endometriosis. Obviously, endo is a huge part of infertility because we see it so often in so many patients. If you have endometriosis, in many cases, it can go unnoticed because not every woman knows that she has endo. For women that do have endo, a very substantial portion will, or proportion, I should say, will experience infertility or fertility problems. And a very significant number of patients with infertility actually have endometriosis. The problem with endo is that without laparoscopic surgery, you cannot accurately diagnose endo. You actually have to see it, biopsy it, send it to pathology. They have to see the presence of endometrial glands or stroma in the tissue biopsy, and then you can confirm that you have endometriosis. So nothing else is an acceptable surrogate or substitute. Now, certainly there is no question whatsoever that many people have tried to find tests, and Receptiva is one of them, and there are some other tests that have been looked at to try and tell people if they have endometriosis or not. These are blood tests which are being done. The reality is they are very poor tests of whether or not you have endo, and they do not indicate whether or not you have endo. So you really need surgery. And what many fertility centers plus specialists fail to do is accurately treat and or deal with endo, because they just want to kind of plow you through your fertility treatment. And so it often gets overlooked, or they feel like it's not important. I was discussing this with a recent patient from the UK who said, well, I'm not sure if I have endo, and very clearly from her symptomatology she did. And she said, my doctor told me it wasn't important if I had endo, that it wouldn't make a difference with IVF. Nothing could be further from the truth. We know very clearly from many studies that if you have endo, it can impact your fertility chances, even when you're doing IVF. And certainly here at VRC, we use special protocols when we know you have endo, which should help enhance and improve your chances of success. So, and some of that can include surgery. So the problem is there's always this kind of juxtaposition of the urgency to get people into treatment versus are we really benefiting the patients? And so this new study, which is coming out in Human Reproduction, it's actually not out yet, actually looks at what the changes were in outcomes of patients that were diagnosed before they started their fertility treatments versus patients that were diagnosed after they had started some fertility treatments, to see, is there a difference in the outcomes? And this is very, very important data, because that's what people really want to know. Should I be checked before I start all my fertility therapy to make sure I do or do not have endo? Or should I jump into my treatments first? And what's the outcome difference? And am I going to need more? Am I going to need less? Is there going to be a difference? So this study looked at precisely that. So this is very interesting data. It's out of Australia, in Queensland, in Brisbane, Australia. And what they were really looking at was data from a large group of women who had agreed to be followed through their lifetime with data linkage sets, meaning they have socialized medicine down there. So they are able to follow these specific cases in registry data and then pull information about what has happened to these women over time. So very, very cool kind of data set to be able to use. From that, they actually had a very, very large number of women. It was over 13,000 that were initially followed. And from that 13,000, they had about 1,300 plus minus that actually were diagnosed with endo and underwent fertility treatments or didn't undergo fertility treatments. So that's the group that they were looking at. So pretty robust data. These are a lot of women. It's not a prospective study because you can't prospectively know or not know if they have endo at the same time. You'd have to know or completely not know, and then to go and find them out would be very, very difficult. So this is as close as we're going to get. So the women were born from 1973 to 1978. They had their diagnosis established one of four ways. So one was self-reported, which is admittedly kind of questionable. These were women that would say that they had symptoms of endo and were therefore treated for it with medical treatment. There was a group that had laparoscopic resection. There was a group of patients that had visually confirmed endometriosis, meaning they had laparoscopy and saw it there, but it wasn't resected. And then there was another group that just kind of was diagnosed with endo, and they didn't define exactly what that meant. So they then went into looking at these. So 13,508 women consented to the data linkage, and 1,322 of them had undergone an assisted reproductive technology cycle in Australia by the time they were somewhere between 42 to 47 years. That doesn't mean they did it in that time frame, but rather that they did it by the time they had reached that age. Of the 1,322 women that used the ART, 34.7% or 459 had endometriosis. So kind of very cool overall. Lots of numbers, robust data for us to use. Okay, so about 65.6% were diagnosed before they had their first ART cycle, and 34.4% were diagnosed after they had done some kind of fertility treatment. So the first thing to point out here is, I would say in general, that's the opposite in North America. Frequently, patients are kind of railroaded into therapy, so they kind of get shoved into doing fertility treatments because that's where the money is at. In many instances, reproductive endocrinology and infertility specialists do not do a lot of advanced minimally invasive surgery, if any, and they look at it as a financial loss, so they just want to kind of push people into treatment. We very much don't do that here. I do all of my own surgery, and we try and focus on giving patients the best care possible. So when I think that they should be offered surgery, I tell everybody, here are your options. Surgery is an option for you. Here are the risks, here are the benefits. What would you like us to do? So we don't push people into therapy. And I think in general in North America, people do get pushed into jumping into treatment before they get a diagnosis of whether or not they have endo. So when you look at the actual numbers, they kind of went into some added details. They said on average, women that were diagnosed before their first assisted reproductive technology treatment were about 5 years younger at the time of their diagnosis than women that were diagnosed after. And it took them about 2.08 years of infertility to be diagnosed with endometriosis for the women that had started it after their first treatment. So it took a lot longer to be diagnosed. So women that did have the diagnosis earlier were diagnosed about 2 years before their ART. Women that have the diagnosis made later were doing treatments for about 2 years before they had their diagnosis. So a big time gap difference, a 4-year difference overall between those that were diagnosed before and after. So no real major differences between the two groups other than there was a very slight 2% difference in the number of patients that had never had a baby before. So we're going to go to table 2, and Tark's got that pulled up for you there. So in the first age group, they didn't actually show that it was statistically significant after they controlled for all the confounding variables. So there were some differences before, but after they did confounding variable adjustments, they said that the age actually did not make a difference. So in terms of IUI, you can see that in the group that was diagnosed after their first treatment, it was 10.1%. And in the group that was diagnosed before, it was only 7.6%. So in other words, more patients went through IUI if they were diagnosed after than they did if they were diagnosed before. Conversely, more patients that were diagnosed before ended up doing IVF only, 71.4% versus 53.8%. So that diagnosis of endo was probably promoting people to jump into IVF more frequently than that would have been if they were diagnosed after. Overall, when they looked at the proportions, they showed that patients getting both treatments was 20.9% in the group that was diagnosed before their first treatment versus 36.1% for the group that was diagnosed after. So that, in other words, means you are getting more people going into treatment if they're diagnosed after the first therapy than for the patients that were diagnosed before. So kind of a significant number. In terms of number of ART cycles, this was highly significant. So you can see there that the group that had 1 to 3 cycles of any kind of assisted reproductive technology, 46.5% in the group with the diagnosis before. So kind of the majority of them only needed 1 to 3 cycles, whereas the group that was diagnosed after, only 29.1% of them were in that low number. 4 to 10 cycles of treatment, which is a lot, regardless of what you're doing, 42.5% in the group diagnosed before they started their treatment, 49.4% in the group that was diagnosed after. So you're starting to see an increase in the number of patients who did multiple cycles. And then really kind of staggering 11 to 36 different treatments, which is absurd. It's probably unethical. There was only 11% in the group that had been diagnosed before, whereas 21.5%, nearly double the number, are getting these very high levels of treatments or high numbers of treatments when they're diagnosed after, which probably means they failed a bunch of the first treatments, then they got diagnosed with IVF or with endometriosis, and then they had to start the whole process all over again. So again, very concerning that people are being put through these huge numbers of treatments. I'll go into the birth data in a minute. As you can see off to the side there, it was not statistically significant. But when they looked at it after controlling for variables, it actually was, and I'll show you that in a second. What also they showed was whether or not you became a mother under the age of 35 or over the age of 35 in terms of having a birth. And here, again, they did not show a significant difference between the two groups. So if you flip over to table number 3, don't worry about the age because, like I said, that was not a very clinically significant or meaningful factor. So in terms of IUI, they definitely said that your chance of needing IUI or doing IUI if you were diagnosed after your first treatment was much higher. So more people were doing IUI at 114% increase, very highly statistically significantly different compared to the group that had been diagnosed before. So very important in that the group that is being diagnosed after is undergoing a lot more treatment. And as I'll show you in a moment, they were doing it a lot more times. So again, when you look at the number of patients doing 4 to 10 cycles for ART treatment, very significant, 134% increase when you look at the crude number, 121% increase when you look at the adjusted number where they're adjusting for all the variables. So again, a huge increase in the number of patients that are needing multiple cycles of treatment if they're diagnosed after instead of before. And then for the 11 to 36 group, it's a 309% increase over baseline for the group that had been diagnosed after. So again, huge numbers of cycles being done with a very significant increase in your risk of needing that many cycles if you ended up with a diagnosis that occurred after the fact rather than before. So very important. When they looked at birth in terms of did you actually succeed, your chances were 33% less of achieving a birth if your diagnosis occurred after you started treatment rather than before. So if anything is important here, it's actually that one number, because live birth is always what we're looking for. And this is essentially saying that if your diagnosis occurs before your treatment start, we can probably adjust things sufficiently to improve your chances of success so that you actually have a better chance of achieving a live birth. Whereas if you start after, you may have gone through multiple cycles. That can actually worsen your endometriosis because we're stimulating your estrogen. And then that can make things a lot more difficult for you to succeed. Plus, based on the time frame that they were looking at, these women were waiting an additional 2 years just to get to the diagnosis of endometriosis. And that kind of time span can allow for a lot of aging, diminishment in the quality of your eggs, diminishment in the quality of the sperm, a reduction in overall success rates. So does it make sense to get diagnosed before you start your infertility therapy? Absolutely it does. And that's why we always talk to our patients about this and say, if you have a suspicion for endometriosis, one of the treatments is to undergo surgery and either reduce or treat the endo at that time, or take the medical measures that we can with things like GnRH agonists, GnRH antagonists, Visan, all sorts of different therapies that we have, including natural supplements that we use to try and reduce the impact of the endo on your cycle. So don't get pushed into doing treatment. And I think this is the message I really wanted to give. And I love this article because it fits very much philosophically with what I believe in. Don't get pushed into doing treatments because of the fact that your fertility center says, don't worry about endo. You actually should worry about endo. And here's some very good evidence that demonstrates that it will increase the number of cycles you need. That's going to increase your costs. It will actually decrease your chances of success based on that live birth data. And so it makes a lot of sense to get your diagnosis ahead of time. Now, should everybody jump out there and do laparoscopy? No, of course not. There are risks associated with the procedure. And so not everybody is cut out for doing a surgery to get the diagnosis of endo. But if you have symptoms, the symptoms can be fairly predictive of having endometriosis. So as a result, it makes a tremendous amount of sense to have that discussion with your reproductive endocrinologist. Make sure that they have an idea about whether or not you have endo. And if they're suggesting that even the possibility exists, it may be worth the risk of the surgery, especially if you have a good surgeon, to undergo that treatment and see whether or not you have the endo and get it treated at that time, which can make quite a significant difference. And if you look at the data on treating endometriosis, it actually does improve your chances of conceiving even naturally. So thank you for watching that segment of the show. Is it a factor of fiction that diagnosing endo before your fertility treatment will improve your chances? It appears to be a fact. You can improve your chances by getting your diagnosis before, rather than doing treatments first and then getting diagnosed with your endometriosis. So make sure you hit that like button, comment, and we do want you to subscribe, especially on our rapidly growing YouTube channel. Appreciate you joining us for that part of the show. We will now take live questions, and I'm sure Tarek has been collating the good ones for us. So do we have a bunch?
We have
a lot. Yeah, is it another band? Last week, by the way, was an unusually busy show for us. So thank you for helping us grow. We love that. And if you have friends that are struggling, or you know people, or you're on your own social media platform, make sure you give us a shout out so that we can get others watching the show as well. Yeah.
Dr. Vickery, do you have a clinic in Toronto?
Yes. We have multiple clinics that we work out of in Toronto. And of course, these days, everything can be done virtually. So it's easy to manage whatever we need to manage for patients.
Happy Thanksgiving.
Happy TG.
Do you give photos of the embryo to your patients after transfers?
Yeah, absolutely we do. So our embryologist is very fond of doing that. So she does it. You just have to ask for it and we provide them. We have your embryo actually up on a giant 55-inch high-resolution Sony television in the OR, so you can see your embryo. And then you can actually have us email you a very close-up picture of the embryo from under the big, powerful microscope via email right after the procedure. So Dr. Khosravi, our lab director, does that.
A little bit of a long question.
A long question? Okay.
Just give me the heads up.
All right. That's right.
Even referencing YouTube videos.
Oh, cool. Even better. Yeah.
Hey, Dr. V.
That's me.
Thank you so much for all the advice on these videos.
Yeah.
After failing 2 transfers, my 3rd transfer finally worked, and I think it's because I'm taking melatonin as well as taking lower estrogen.
Awesome.
My question is this. I'm currently taking 3 milligrams of melatonin nightly. Should I taper or just take this until delivery? And should I continue taking this while breastfeeding? I saw your older melatonin video and thought it was helpful, but I think it would be great if you can do an updated video because so many women still seem to think that melatonin is harmful for pregnancy. Thank you so much.
Yeah, there's no harm to melatonin in pregnancy, so you can take it. And I would actually argue that your embryo and your fetus now does not appreciate significant changes in your physiology. So once you've started something, generally speaking, keep homeostasis and stay on it. There's no harm to the pregnancy whatsoever. So you are completely within your rights to stay on the melatonin. And I'm so glad that what we expressed on the show has worked for you. Low estrogen is super important, melatonin as well. So congratulations. Big round of applause from our whole group and family. That's amazing. I love it when the patients tell us that they watched our show and then they were able to succeed. That's what we started this show for. It was literally just to help people. So I'm really thrilled to hear that that worked for you. That's amazing. Very cool.
What are the benefits of PCOS patients taking NAC and Inositol? I know you recommend them among other things, but how exactly do they help? And how soon before an FET can any immune therapies be done? If all goes well, I'll be doing one this month.
So Inositol, no one's quite sure. Sorry, NAC, no one's quite sure. Inositol actually is quite good at sensitizing you to your insulin levels. So it has to do with insulin sensitivity. So there's no reason why you can't do it with Inositol. NAC also has been clinically shown to be beneficial, as well as coenzyme Q10. So we always give all 3 of those: NAC, Inositol, and coenzyme Q10. How soon can immune treatment be initiated? It depends on which immune treatment. So that I can't give you a blanket statement, but there are some you start months in advance, and there are some you start right around the time of the FET. So, for example, if you're taking steroids, you start that around the time of the progesterone start. If you're doing intralipids, you start 2 weeks in advance. If you're doing subcutaneous IG, we start like a month or more in advance. So it all depends on which therapy you're talking about. But all of them can be done, generally speaking, before. I'm not a believer in starting immune therapies after, because you've missed the boat. Great question.
How can we differentiate bleeding in pregnancy between miscarriage versus a SCH?
Oh, well, without ultrasound, you can't, or blood work. So if it's very early, like less than 6 weeks, the only way to know is to do your beta HCG level. If your beta HCG is rising a minimum of 60%, you are likely safe. You should still be seen by a physician and checked, because you don't want to make the mistake of missing an ectopic pregnancy. But if every 48 hours you're going up by a minimum of 60%, it is likely still a viable pregnancy. If you're past 6 weeks, you just go in for an ultrasound. If it's brown blood and you've already seen a heartbeat, we don't get too concerned. If it's bright red or it's fresh, we're definitely much more worried. And then, of course, there's the whole issue of your blood type. If you're Rh negative, you need to be treated with RhoGAM, especially after 6 weeks. So definitely always get seen if there's bleeding. Never just play it down. But you need either blood work or an ultrasound to reassure yourself that it's a subchorionic hemorrhage, versus a miscarriage.
What about a Lupron depot?
Well, if you mean Lupron Depot for endo, it's great. There are a very vocal group of people that believe that Lupron causes tremendous harm. I can't say that I've seen it in my clinical practice, but I caught wind of them because they initially wanted me to help them with their cause, and I was open to it, but then found that their agenda was purely just to kind of make sure they condemned Lupron, and I'm more open to the science of it. If it's bad, I want to know, but I don't have proof yet that it's bad, so I'm not going to condemn something that's given a lot of women relief without knowing for sure that it's bad. So in any event, there are some people that are against it, but Lupron can be very beneficial for endo. We use a combination of Lupron with letrozole for 3 months for our patients with endo. Alternatives would be Vizan, which is available in Canada, but not yet in the States. And then there's now Elagolix, which is a GnRH antagonist, which is kind of similar to doing what Lupron does, but not quite the same and has less side effects.
Is a medicated or natural FET more effective?
Well, it depends on which week you're reading which study. So literally every week a study comes out saying natural is better. And then the next week a study comes out saying there's no difference. I have yet to see one that shows that the hormone ones are better. So a stimulated cycle is rarely better. But we certainly have seen many that show that there's no difference. We use kind of a modified natural. So we use letrozole and then we minimize the amount of estrogen patients are getting. And that seems to be working really, really well. So we don't go pure natural and we don't go pure modified. We do like a blend.
If you have bleeding from SCH, will vaginal progesterone still be adequately absorbed?
Yeah. Bleeding from a subchorionic hemorrhage will not alter your progesterone absorption because that's going into the walls of the vagina. Unless you're bleeding so heavily that you're washing out the progesterone, which is unlikely, then you don't need to worry about that at all.
What's your advice for someone who has already been diagnosed with endo, low AMH, poor response to IVF meds after more than 18 days of stim, and high abnormal rate 3 out of 4?
So first of all, I'm sorry you're going through all that. That's terrible. Don't do a stimulated cycle. You're just making your endo worse and you're probably not going to make many eggs. So I'd have to know more specifics about your cycle. You could probably get away with either a mini stim cycle or even just natural cycle. But those are cases where you really have to consider the value of using an egg donor. So there are some different approaches that we'll use for those cases. Full-on, hardcore, tons and tons of medication is rarely the right answer. It doesn't work. And all you're really doing is spending a ton of money, getting very frustrated, and getting the same number of eggs you'd get if you just did it with way less meds. So we tend to take a much more gentle approach with those patients than the super aggressive approach.
What is silent endometriosis and can it affect the FET?
Yeah, silent endo just means you don't know that you have it, and it absolutely can cause a problem for your FET. So about, depending on which study you read, 25 to 45% of women don't know that they have endometriosis. In other words, they have no symptoms. So that's what silent endo is. And if you don't know that you have the symptoms, the problem that you run into is that it can be there immunologically active and interfering with your ability of the embryo to implant, but at the same time quiet enough that you don't know that it's there. And so you don't know that you need to treat it. So yes, it absolutely can alter your chances with an FET. And it's very common to have silent endo.
When preparing for a natural frozen embryo transfer, how much PIO do you prescribe? How much suppository is the PIO titrated based on size and weight?
Well, we titrate based on level. So we always start with 50 milligrams a day. And after 3 days, we check your levels. The vaginal, it depends on which one. So the Prometrium, we use 203 times a day. Crinone is one gel pack twice a day, and endometrine is 1-3 times a day. So it depends on which one you're using, but we just follow the normal recommendations for those.
Hello, doctor. I am from Uganda and want
Wow.
to do IVF treatment, and I am 48 years old.
48?
48.
Okay.
That's it. What can I do?
Well, being completely honest with you, I would not recommend you do IVF at 48. The chances of success are probably around 1%. So using your own eggs would not really make a ton of sense because your chances are going to be very, very low. If you do want to try, you need to see about your AMH and how many eggs you have. And if it's very low, just try kind of a very mini stim or a natural approach. If it's high enough, you could try a more significant stimulation. But again, keep in mind that your chances at 48 are going to be extraordinarily low. You legitimately have less than a 1% chance of success. So I would be very, very hesitant about letting you do that, especially if you have to pay for it. I don't know what the situation is in Uganda, but you got to be very, very careful.
I did a bunch of tests after recurrent miscarriage and noticed that one of the results mentioned that I had a bulky uterus, but no fibroids.
Sure.
Though I request more tests from my doc, never mentioned this. Thanks.
I'd probably be asking about whether or not you had adenomyosis. A good ultrasonographer or physician radiologist should be able to tell from the ultrasound. If not, an MRI will tell you. Bulky uterus could mean adeno. Adeno can impact your success rates. It's very much like endometriosis, but in the wall of the uterus. So when it's there, that also needs treatment, and the treatment is medical most of the time, where we kind of suppress your adeno by putting you on Lupron and letrozole. So I would definitely have someone look at that carefully. A bulky uterus can be problematic.
My clinic froze my embryos, which they graded 4 CD, 3 CC, 3 CV, day 5-7 blastocysts. These seem to be poor grades, but are they still viable? Does poor grades predict birth defects or miscarriages?
So unfortunately, those are poorer grades. And in particular, most of the ones you read out were scoring the actual inner cell mass, which is the part that becomes the baby, as being a C grade. So there is data that we reviewed several months ago on the channel here that shows that the morphology score of the embryo is important for success. And A's and B's are generally roughly the same, but C and D definitely has a lower success rate. Is it going to translate into a higher risk of miscarriage? Probably. Is it going to translate into a higher risk of the baby having an abnormality? Probably not. Most of those will actually end up miscarrying, so it's unlikely that'll actually numerically impact you.
Hey, Dr. V, what transfer protocol would you recommend if you have mild adeno in a small area of the fundal part of the uterus?
3 months of Lupron and letrozole, wean off the Lupron, do 5 extra days of the letrozole, take virtually no estrogen if you can avoid it. If you do, you just want to take it orally in a minimal amount. So start at the lowest possible dose for you. Take all of the endo supplements, so NAC, curcumin or turmeric powder, coenzyme Q10. Eat really healthy. If weight's an issue, keep your weight down. Eat a very healthy diet, very clean diet, exercise every day. I'd probably see a traditional Chinese medicine specialist. Mary Wong is in Toronto. She's been on our show before. She's excellent. Or a naturopath, Jen Strong or Laura Jasmine in our team, all amazing docs. So they can all really help you as well. But you want to be super low in hormones, very, very low in estrogen supplementation. Progesterone in oil, progesterone vag suppositories when the timing is right. Yeah, that's basically it. Melatonin, all the other stuff, aspirin, the things that we routinely tell people about.
Today you are officially Dr. V.
Today I'm officially Dr. V?
Yeah, everybody's giving you the hey Dr. V.
Oh, hey Dr. V. So I wasn't Dr. V until today. It's
Okay,
like,
it seems like there's
in
no
your
other-
mind,
there's
I
no
just
other
wasn't
reference.
Dr. V
Now it's
before.
clear.
All right, I'm officially Dr. V apparently. That's good.
Hi, Dr. V. If a woman is going through infertility and already has one reproductive issue such as PCOS,
Yeah.
should endometriosis be ruled out before IVF transfer since endometriosis can be silent?
Well, if you have symptoms, yes. If you just have PCOS, no. Although PCOS and endo are connected to some extent, there are studies that show you're at a higher risk. So that might be a reasonable thing to do. Again, don't forget, as I mentioned earlier, there are the risks of the surgery. So if you have risks of pain, or symptoms of pain, pain with intercourse, painful bleeding, anything like that, heavy, really disastrous periods, severe cramping, bowel symptoms, bladder symptoms, any of those things that are kind of the hallmarks of endometriosis, it's at least worth a discussion and consideration. Now, granted, if you have 20 embryos because of PCOS and you want to try one, I don't think anyone would say don't. But if surgery is easy and you have a good surgeon, and please make sure you have a good surgeon, because not all surgeons are created equal, for sure. So if you have a good surgeon on your side, then make sure you get checked out and have them give you an opinion. And sometimes we can even tell from a vaginal examination whether your risk of having endo is higher or lower. So there are things that can be done to kind of gauge your chances, and based on that, make an informed decision that's right for you.
Why do IVF patients need their TSH under tighter control than the general population of pregnant women?
Well, the general population actually needs it. It's just that as REs, we don't want anything to go screwy. So we're just really very careful about it. But the recommendation for all women getting pregnant is that your TSH be under 2.5. So that's not specific to fertility patients. It's all pregnant women. It's just that we follow that much more closely because our population is so in tune with everything out there that they all know about it. And so we follow it very, very closely. I bet you if I asked half of my colleagues, they wouldn't even know that they're supposed to keep the TSH under 2.5 for the ones that do general OBGYN. And even some fertility specialists don't know it. Yeah. Am I still Dr. V?
No, this is a straight question. Like, hey, you know what I mean? There's no even introduction here. My RE suggested waiting 3 cycles after having a DNC for a loss. This is the first doctor to suggest this. What is your thoughts?
Proven to be incorrect. So they did a study a while back that showed that there is absolutely no benefit to waiting whatsoever. So you do not need to wait. And arguably, if it was a clean DNC, there were no complications, that scuffing of the uterus actually makes it stickier. So you may actually benefit from going sooner rather than later. On the flip side, if you had retained tissue, if there were complications, if there's any chance of infection, you need to make sure that there's no infection in there before you try your embryo transfer. So that can play a role as well. Great question.
Why is low estrogen important for transfer?
Estrogen is pro-inflammatory and it is not helpful for making babies. So you want a low level of estrogen when you're going for your transfer. Even when you look at your natural menstrual cycle, after the mid-cycle surge, there's this little blip of estrogen and then it trails off very quickly. What we're doing in RE or REI is pounding people with estrogen and then we continue it. That's not mimicking the natural state. So you want as low an estrogen level as possible, for sure.
I've been taking 5 milligrams of melatonin to prepare for my FET. Should
Perfect.
I only be taking 3 milligrams or is 5 okay?
Nah, 5's fine. Don't worry about it.
Hi, doctor.
Hello.
Crystal that told me, I'm just reading it. I'm not, I don't write them. Okay. Hi, doctor. Crystal that told me to join. What is adenomyoma?
Adenomyosis?
Adenomyoma.
Yeah.
And can't it stop you from getting pregnant?
Okay, so hi, Crystal, and hi, patient. I don't know who you are because Tarek never reads your names out, but no, I don't think we should. So, yeah, so an adenomyoma is a collection of adenomyosis, which is the stuff that's coming out with your period, but turned into like a hard kind of ball inside the wall of your uterus. So it's like a fibroid, but they're way harder to deal with because they really don't have a clear plane that differentiates it from the uterus when you operate on them. And they're very difficult to treat and get rid of because there's no clear margin. You can't tell where the adenomyoma is, where the normal uterus is. I hate adenomyomas. So can it interfere? Absolutely. They're very inflammatory. They're very aggressive. They do a lot of damage to the uterus. How do you treat them? It's either surgery or suppression. And if it's big enough, suppression will not be enough. You actually need the surgery. So that's something where you have to see an expert gynecologist, like truly an expert gynecologist. It is not something to be done by anybody other than someone that has a lot of experience dealing specifically with difficult adenomyoma surgery. I would say 95% or more of generalists out there will not have a clue what to do in that circumstance. So you really need to see someone that has a lot of experience for it.
What supplements do you recommend in preparation for transfer?
We should just start every show with that, because like literally every show we get asked. You should just put up a thing in the middle of the show. Yeah, that says before you ask. So this is a very common question for us. So supplements, it depends on what your background history is. The basics, aspirin, your prenatal vitamin with high folic acid, the omega-3 fish oils, melatonin. Those are the mainstays. Oh, and vitamin D, and iron if you're low in iron. So all 6 of those are really critical for you to be on to improve your chances. If you're PCO, you want to add in inositol, NAC, and coenzyme Q10. And if you are endometriosis, you want to swap out the inositol for curcumin powder, which is turmeric powder, basically. So it depends on what's going on with you, but the basics are there, and then you need the extra ones based on your health history or conditions.
In a modified natural FET, how much or little E2 do you prescribe, and how much letrozole?
As little, we use 5 milligrams of letrozole. We use as little estrogen as we possibly can. So we use none where possible. We use 2 milligrams to start if we have to of estrase, and then we bump it up from there. But we really try very, very hard to keep your estrogen levels as low as humanly possible.
If IUI worked for the first pregnancy,
yeah,
would endo possibly be a factor in a second pregnancy with IVF and FET?
I'm not sure I see the connection. So if you were successful with your IUI in your first pregnancy, there's no bearing on whether or not you have endo. You might have endo, you might not, but the IUI being successful does not suggest whether or not you have endo. There are lots of people with endo that are successful with IUI. So is it going to be a factor for your IVF? Well, if you have endo, it'll impact IVF. But if you don't have endo, obviously it's not going to play a role.
Is it safe to continue to take NAC after a positive beta?
Yep. NAC is safe. There's no harm.
How long does a lap surgery to clean out endo last before another surgery is potentially needed to tackle the regrowth?
6 months to a year.
We did our retrieval 2 months ago and we'll be doing our transfer soon. Should I still be taking ASA before transfer?
Yeah. Definitely stay on your ASA. You want to stay on ASA right through the whole pregnancy. Watch our video on aspirin and IVF. It's on the YouTube channel. Is that one of our more watched ones? Yeah, I think it is, right? Sure, yeah. 14,000 or something like that. Yeah, so go to the YouTube channel, pull up the video on aspirin. Tarek will probably put the link up when he does the edit for this one. So yeah, check out that link and go watch that video because aspirin is very beneficial in a lot of different ways.
Do you allow patients to transfer 2 embryos? Also, if they are sex embryos, Can we pick which ones we want to transfer? We are looking at doctors around the GTA, and so far, you are one of the top doctors in our list.
Yeah, boom. Okay, so thank you for the compliment. I appreciate that. No one in Canada is allowed to transfer embryos based on sex. So let me dispense with that quickly. And you shouldn't know what sex they are unless there was a genetic test done for sex-related genetic problems. So otherwise, if somehow you know if it's a boy or a girl, no, you cannot pick which sex you want because we're not allowed to do sex selection in Canada. It's totally 100% not allowed. It's actually a federal offense. And I love you all, but I'm not going to Kingston Penitentiary for any of you. So in that regard, you can't do sex selection. As far as 1 versus 2, we do allow 2 in certain circumstances. So if you are older when you made your embryos, if you don't know that they're genetically normal, and if you are aware that they're genetically normal, then we would definitely be pushing you to just do 1. If you don't know if they're genetically normal, you were over the age of like 37, 38, yeah, we're comfortable doing 2, but we try very hard to just do 1 at a time.
I was referred to an OBGYN because I believe I have endo.
Yeah.
They told me that laparoscopy surgery is not worth it because I'm older and time is not on my side. Also with COVID, everything is backed up. They told me to stick with a fertility clinic. I paid to have a blood test done to determine if I have endo, and it came back negative. My doctor told me I don't have severe endo. I will be 34 next month, but I desperately feel like I have endo. Should I put everything on hold and request the surgery? I was told the wait list is over a year.
Yeah, Tarek wants to answer that. What's your opinion?
She should get tested for sure.
She should get tested for sure.
34 is not that old.
34 is not that old. See, he's right. He could answer that question. Okay, I'm leaving the show now. Tarek's taking over. So yeah, no, I agree. The answer is, first of all, you're not even close to being old. So I fundamentally disagree with anybody telling you that there's a rush for you. I also disagree that it should take you a year. If you shop around doctors, it will not necessarily take you 1 year to get into surgery. So yeah, I'm not worried about that at all. And yes, if you feel like you have the symptoms, as I mentioned at the start of the show, the Receptiva test is absolutely useless. It does not diagnose endo. So don't bother with those test results. They don't mean anything. Could you still have endo? Yes, you could. Is it worth the laparoscopy at 34 if you're quite sure that you have it? Absolutely it is. That's a no-brainer. So yeah, I would get checked out for sure. Yeah. And I'm quite surprised to hear that somebody said it was not worth it because of your age. I would see a fertility specialist instead of a gynecologist, but see a fertility specialist that isn't trying to plow you into IVF.
How do you test for silent endometriosis?
There's only one test for any kind of endo, and that's laparoscopic surgery. There is no test, guys. No matter what you see, no matter what you read, there is no test for endo other than having surgery. You got to have surgery. They got to see the lesion, biopsy the lesion, send it to pathology.
If I'm 39 and have my tubes tied, even though I had an HGS and came out as my tubes are not blocked, but can I do a natural cycle or a mini IVF? For sure, my tubes are tied, but I had 2 full IVF cycles, and one was ectopic, and the second did not take as my progesterone was high. So I believe my ovulation passed. I can be wrong, but I'm waiting to get an appointment.
Wow. Okay, so if your tubes were tied, they could have reopened, although that's extremely rare. I'm sorry you have to go through the ectopic and the failure. You can do any kind of IVF with blocked tubes. So yeah, your tubes are irrelevant doing IVF. Can you do a natural cycle to get pregnant on your own? I would need to verify what your tubes look like, but yes, just keep in mind that the chance of pregnancy is going to be low because your tube probably has some stricture, and the chance of ectopic would be very high. So as long as you're being monitored very carefully, there's no reason why you can't try on your own, but IVF is going to bypass your tubes always. So there's no reason why you can't do any version of IVF, whether it's natural cycle IVF or stimulated IVF. IVF would be fine.
Hi, Dr. Victory. I had Provera to induce my period and started letrozole 5 milligrams on day 3 to 7.
Okay.
I'm not on day 12. My periods have not stopped yet. What should I do?
Well, if you're PCO and you have not had a regular period for a long time, you will likely be like this for 1 to 2 months till everything in you clears out. If you're still persistently bleeding, you need to be checked because it's entirely possible there's some overgrowth of the lining there. And that has clinical implications that can be serious, so make sure you get evaluated. But your bleeding has nothing to do with when you start letrozole. So in other words, if you get your period and day 1 of your period is day 1 of the cycle, then on day 3 you start your letrozole. If you're still persistently bleeding, like I said, you may need some assistance in the next cycle or investigations, but you should still go ahead and start your letrozole. There's nothing wrong with that.
Hi, Dr. V! Exclamation mark, exclamation mark, exclamation mark.
Thank you. Hello.
We should get a lot of likes for that one. That's cool. My RE decided to put me on 2 milligrams of estradiol from now until my IVF cycle in November. Can this fuel the growth of fibroids? My last ultrasound showed 3 tiny fibroids growing. Don't use birth control due to poor response at first cycle.
2 milligrams of estradiol prior to her first transfer or her first cycle?
Until my IVF cycle in November.
Oh, so you're getting estrogen priming? Yeah, it probably will increase the growth of your fibroids, but if they're small, probably not enough to make a difference. So unless they're inside the cavity or very close to inside the cavity, I definitely wouldn't worry about that.
Regarding the question regarding the poor graded embryos.
Yes.
And how you said there is a higher chance of miscarriage.
I like the follow-up, eh? So they're watching and they're back into it. Yeah. Okay, that's cool.
They're watching the YouTube video. They click on that. They come here.
And then they come here.
Yeah, it's good. It is good. I also think it's
all right. That's cool. Yeah.
So regarding the question here.
Yeah.
You said there's a higher chance of miscarriage. What about if they are Pgt normal? Would they still be likely to miscarry?
Yeah. Well, I don't want to say they're likely to miscarry. A Pgt normal embryo with a poorer morphological grade still has a lower chance of success and has probably a higher chance of miscarriage, because remember, there are 2 parts to your embryo. Part 1 is the genetics of the embryo, and then there's all the other parts of the embryo that go into making the embryo healthy, successful, energy efficiency, all the right enzymes, all the right proteins, all the ability to process, to invade into the endometrium, create that syncytiotrophoblastic tissue where their placenta eventually develops. So if you don't have a really strong embryo, it may fail in that part of things, even though the embryo itself is genetically normal. So there are a lot of things that go into this that we still don't even really fully understand. And so, yes, there can be a higher risk of miscarriage for sure.
4 MMC around 6 weeks. IVF cycle 9, retrieved 7, fertilized, and 2 blastocysts, and 1 Pgt normal 3 AA. Were the miscarriages due to egg quality?
Probably, based on the fact that you're getting very low yield and very low numbers, but you did end up with 1 genetically normal. So I mean, it's impossible for me to know, but if you had 4 6-week miscarriages, you need investigations before you do a transfer, 100% for sure. You should be evaluated for infections, for immune problems, thrombophilia screen, vitamin levels, excuse me, the shape of your uterus, you name it, everything that's out there that's available. 4 6-week miscarriages in a row is way too many. Almost for sure they'll be able to identify something and then deal with that and improve your chances. And I certainly, if you were my patient, would not let you do a transfer unless you were doing a whole bunch of treatments first to try and improve your chances.
Could you become infertile after having multiple babies back to back?
Yeah. I mean, there's all sorts of scenarios where that could happen. Could be your partner, could be you, infection in your tubes, worsening of endometriosis. If you had multiple C-sections, it decreases your chance. I mean, there's all sorts of reasons why that could happen. I could probably sit here for half an hour and pontificate on that one. So, yeah, very possible.
Is silent endometriosis only diagnosed through laparoscopy?
All endometriosis is only diagnosed through laparoscopy.
How would you treat someone with silent endometriosis? Laparoscopy is not an option. Would an immune protocol help?
Probably a little bit of an immune protocol, more realistically, suppression. So Lupron and Letrozole, Vizan, Elagolix, various medications, GnRH agonists or antagonists, I don't care about the brand, which will facilitate dropping your estrogen levels to starve the endo from their food supply.
At what point during an FET cycle should I start taking baby aspirin?
Before you start your whole stimulation process.
Would you be able to do a fresh transfer after doing estrogen priming and testosterone priming?
Yes, you would be able to do a fresh transfer. Whether you should or not is a different question. So keep in mind, if you need estrogen and testosterone priming, the chance that your embryo will be genetically not normal is much higher. And so that's a situation where and I don't advocate for PGT for everybody, but in that circumstance, I would actually advise you to consider doing PGT. So you can't do a fresh transfer if you're doing PGT. That's always frozen. So I would definitely consider it.
Hey, Dr. V.
Me again.
Which clinics in Toronto do you work at? Is Create one of them?
Create, a little association with IVF Canada still. We send lots of our patients to my colleagues at Tripod. So we got a bunch of different clinics we're working with.
What level of estrogen are you looking for in a natural FET after surge?
We're not. We don't measure estrogen levels. We're measuring your lining. I don't care what your level is. It doesn't matter. There was a study we reviewed here about 6 weeks, 2 months ago that showed that you wanted over 100 picomoles to improve your chances, but we really don't measure the levels of estrogen.
Happy Thanksgiving, Dr. V.
Happy Thanksgiving to everybody.
What is your suggestion for patients with endo and DOR before egg retrieval for having good quality euploid embryos, planning to start IVF again in 3 months after one failure?
Lots of healthy diet ahead of time, lots of supplements. Like I said, see a naturopath, see a traditional Chinese medicine specialist, acupuncture, that kind of thing. Keep your exposure to synthetic hormones as low as humanly possible, including eating organic so that you're getting, stuff that hasn't been fed hormones into meat and fish and whatever fruits and veggies are out there and so on. And then in terms of yourself, I would be doing kind of a medium dose protocol because you have endo, so you don't want to stim the endo, but you have DOR, so you don't want to miss getting eggs. So those are the situations where doing a couple of cycles with a lower dose is actually better than doing one high dose cycle. The other thing is to consider that you may want to do 1 or 2 cycles of IVF, bank all of your embryos, and then do the surgery to clean up the endo. That's something we do frequently before the transfer. And always, 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 always do a frozen embryo transfer when you're dealing with endo, because a fresh embryo transfer, you're literally putting the embryo into the environment it is least likely to succeed in if you have endo, because if you're doing IVF, we are supercharging your estrogen levels, and that means the endo is maximally activated at that time. To then go and try and stick an embryo in there, it literally defies all sense of logic. It just makes no sense whatsoever.
Also curious if you recommend a trigger shot for ovulation for a natural FET, or do you suggest a natural ovulation?
So you can do either one, and that has been looked at in studies, and there is no difference. So it doesn't really matter. The argument against doing pure natural ovulation is that the timing of your progesterone is really important. And you can't know exactly what time you ovulated. So that makes it harder to time the exact timing of where you're putting in the embryo. So the trigger makes it easier because then we know how many days from trigger to do it.
Hello, Dr. Victory.
Hello.
Would you transfer an embryo that was missing 2 chromosomes? I have gone through 2 cycles, and that's the only embryo I was able to make.
No, absolutely not. No one will do that. If it's mosaic, sure, but not if it's not mosaic. Genetically abnormal embryo like that is extremely unlikely to yield a positive result. And if it did, it's extremely likely to miscarry. And if it didn't miscarry, you're extremely likely to have an incredibly abnormal baby. It would be unethical for us to charge you to do that. So no, I would not be willing to do that.
I'm waiting for the surgery date for endo, but I have also started the endo protocol for meds.
Yeah.
When I have the surgery, will the endo still be present despite being on the meds?
Yeah. You'll still see it. We can tell. Little blebs of endo, and we've got a couple of great videos on endo. Little blebs of endo are very visible no matter what the patient's on. You'll see it. We have a full half-hour video, one of our earliest ones. Yeah, although I don't think it's got as many views as all these other ones. Yeah, probably. So we got like a full. You want to do like an update? Maybe. Why don't you guys let us know in your comments and in likes and thumbs up and all that fun stuff if you want us to do an updated, like abbreviated version of endo. Yeah, do a poll. So, and we can put one on Instagram too. We should do an Instagram poll. Okay. Yeah. So, we have a really great video. You can see me doing mild endo, moderate endo, and severe endo where we're pulling the cyst out of the ovary. And all those surgeries are me. So check that video out. You can see the endo there very, very clearly, for sure.
I'm asking our community. That's what it says, ask your community.
Yeah.
For natural FET, I'm on letrozole from day 2, day 6.
Okay. Yeah, we usually use day 3 to day 7, but day 2 to day 6 is fine. That's okay. You're doing the right thing.
My cycle is usually every 28 days, but I was under a lot of stress recently and had to go on a high dose of prednisone. Mm-hmm. That caused my cycle to be 5 days early.
Yeah. Okay. Oh, yeah, absolutely. Yeah. Prednisone will mess up your cycle if you're taking a high dose.
I have tried dual stem from the follicular phase. We get 2 embryos, but the luteal phase was suspended because there was no eggs. So I tried dual stem again.
Well, when that happens to us, what we do is we do the second half of your duostem with the luteal phase of your next natural cycle. So we just let you release your 1 egg, and then we go and see how many eggs are there, and we try another stem. Yeah. In your luteal phase.
Yes. Thumbs up. Overwhelming majority of people
want a shorter endo video?
Yeah.
Oh, okay. Well, do me a favor. Watch the one we have. If you still want more, let us know. We'll put up another poll. And I don't know how many. I haven't even seen that video forever. It's buried, eh? It's not in like the popular upload section. You guys need to make that a popular upload. It's actually a very informative review. So, yeah. And I looked good that day. I was wearing all Armani. I remember that. All right.
We got 3 more questions that I can see here.
Okay, and then we'll call it quits because it's past 9.
Yeah.
Fire away.
It seems that chromosomal abnormalities is the #1 cause of blighted ovum, but I've read many cases that Pgt tested embryos that end up like this. What are your thoughts?
You can still have blighted ovums with Pgt tested embryos. It's less likely, but it can still happen. But yes, of course, the chance that it's something related to embryo quality or genetics is very high.
I had lab completed by you in March.
Okay.
And there was internal barriers preventing all of the endo from being removed. We're doing dual stem IVF with you in November.
Right.
should I be having another lap surgery before IVF since it's been over 6 months since the original surgery? I have been on Vizan for a few months between surgery and upcoming IVF.
No, because the Vizan will help. And if it was bad enough that I couldn't finish it, it had to be pretty bad because I'm an expert for this stuff. So I would not want to reoperate on you. We would just suppress you with something even stronger than Vizan between the retrieval and the transfer. One more?
Yeah, but I'm scratching my head, I
think. Tarek looks extremely confused for those of you that can't see him.
So this is a follow-up regarding the poor graded embryos.
Okay.
You ready for this?
This is a very persistent question. All right.
Because this information is going to...
It's going to throw me? All right. Here we go. Last question.
Follow-up question around poor graded embryos. What is... they are Pgt normal from a 21-year-old donor?
Then there's an issue either with the egg quality of the donor or your sperm quality from your partner or wherever you got the sperm from. So that would be, or it's a lab problem. So that would be extraordinarily unusual. We do see it, but it's very, very unusual. Yeah. So I would be wanting to go back and find out why the results were like that. Specifically with regards to the sperm and the donor, I would want to know the donor's habits: smoker, drinker, drug user, multiple psychiatric medications or psychotropic medications, heavy caffeine intake, Ritalin, all these different meds people seem to be on these days. And then I would want to know from the standpoint of the sperm, the DNA fragmentation. Does your partner smoke or drink or use marijuana? Because that's a disaster. What kind of sperm quality were we dealing with? Did they take measures to address all of that? Vitamin intake, healthy diet, obesity, estrogen levels in the guy, genetics as well. So all of those things would be really, really important. Yeah. Done. Okay, so thank you for watching Fertility Fact or Fiction. Again, happy Thanksgiving to everyone. Huge shout out to my mom for saving me and Andre from starvation. So Mom, I love you. And a huge shout out to my wife who's finally back. I love you too, honey. And my daughter who let her go. Make sure you like, comment, and subscribe. And please subscribe to our amazing YouTube channel so that we can keep growing that. I think YouTube is where we will have the largest growth overall over time. It seems to add about 10 people every day or two. So we're super excited about that. And if you have questions or concerns, reach out. We are here for you. No one walks alone at VRC. Take care, guys. Have a good night.